Hello students. Welcome to Concepts of Care for Patients with Stomach Conditions. This is part 2 and we're going to discuss right now peptic ulcer disease. So before that, we are going to watch a video to understand better the concept.
Gastric juice is highly acidic because of hydrochloric acid. This hostile acidic environment is deadly for many bacteria, but it is home of Helicobacter pylori, which is the main culprit behind gastritis and peptic ulcer disease. Helicobacter pylori are spiral-shaped gram-negative bacteria with long flagella. It's believed that the infection is acquired through fecal-oral or oral-oral routes. Since poor hygiene is a major risk factor, it's more common in developing countries. How does it survive the gastric acid? The stomach has 4 parts: cardia, fundus, body, and antrum. Body and fundus mainly secrete gastric acid, but the antrum secretes the gastrin hormone and mucus, which has a basic pH value due to bicarbonate. The mucosa of the antrum contains many gastric pits. Helicobacter pylori colonize these pits by adhering to gastric epithelial cells. It is protected from above by the mucus layer secreted by the antrum. Additionally, Helicobacter pylori have an enzyme called urease. It converts urea into ammonia, which neutralizes the acidity of gastric juice. In short, urease and the mucus secreted by the gastric antrum saves Helicobacter pylori from gastric acid. The bacteria release various enzymes and cytotoxic proteins, which damage the gastric epithelium and cause inflammation. The inflammation of gastric mucosa is called gastritis. When the damage is so severe and breaks the entire mucosa, it's called peptic ulcers. If untreated, Helicobacter pylori can even cause gastric carcinoma. Peptic ulcers can be either in the stomach or in the duodenum. Although H. pylori lives in the gastric antrum, ulcers are more commonly seen in the duodenum. Peptic ulcers are characterized by recurrent burning type pain in the epigastric area of the abdomen. It may be associated with nausea, vomiting, loss of appetite, and weight loss. Non-invasive tests like urea breath test and stool antigen test are reliable with good sensitivity and specificity. The serum antibody levels test is another non-invasive test, but it's weaker than the former two. Invasive tests are done with upper GI endoscopy. Biopsy samples from the stomach lining are taken, and to carry out staining, culture, and biopsy urease tests, or CLO tests. Eradication with triple therapy is the treatment of choice for Helicobacter pylori. It's comprised of 2 antibiotics with a proton pump inhibitor. They are given for a period of 1 to 2 weeks. Thanks for watching it. I make animations about interesting medical cases, and I need your feedback to improve them. Please let me know what you think in the comments section.
Thank you so much. It was a very informative video. Very informative video. I've been looking for videos for Helicobacter pylori and peptic ulcer, and even videos that were coming from huge, very important institutions. They were lacking on information, and this video was excellent. So peptic ulcer disease results when GI mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsid, and no longer protect the epithelium from the effects of acid and pepsin. Okay, so very acidic. Pathophysiology: many peptic ulcers are caused by Helicobacter pylori. The most common route of H. pylori infection transmission is either oral to oral. Stomach contents are transmitted from mouth to mouth, or fecal to oral, from stool to mouth contact. Please master this concept, okay? This is very important. As a response to the bacteria, cytokines, neutrophils, and other substances are activated and cause epithelial cell necrosis. So the way the body responds to Helicobacter is by waking up cytokines, neutrophils in the way that they are gonna cause necrosis. Urease produced by H. pylori breaks down urea into ammonia, which neutralizes the acidity of the stomach, because the acid environment for H. pylori will kill the bacteria. But this bacteria is so smart. The bacteria has urease, and urease is kind of their weapon to break down urea into ammonia, which neutralizes the acidity of the stomach. Okay, so additionally, the helical shape of H. pylori allows the bacterium to burrow into the mucous layer of the stomach and become undetectable. That's what I meant before. It's gonna be swimming under the mucosa of the lining mucosa of the stomach, and it's going to be undetectable by the body's immune cells. Although this bacterium does not cause illness in most people, it is a major risk factor for peptic ulcers and gastric ulcers. Okay, types of ulcers. 3 types of peptic ulcers may occur. You have the duodenal ulcers, the gastric ulcers, and stress ulcers are less common. Duodenal occur more often than other types. Most duodenal ulcers present in the upper portion of the duodenum, close to the pylorus. These ulcers are deep, sharply demarcated lesions that penetrate through the mucosa and submucosa into the muscularis propria muscle layer. The main feature of duodenal ulcers is high gastric acid secretion. High gastric acid secretion. Okay? Duodenum, they don't be to be that acidic. Remember, the stomach has a pH of 1. Duodenum, it has to be 3 or 4, something like that. Okay, so the main feature of a duodenal ulcer is high gastric acid secretion. Patients with duodenal ulcers have low pH levels, excess acid in the duodenum for long periods. That's what I'm saying. It's low level pH levels, right? Low pH levels. So it's basically the acid environment from the stomach enters the duodenum. Protein-rich meals, calcium and vagus nerve excitation stimulate acid secretion. Let me repeat. Protein-rich meals. Your intake of high protein red meat. Calcium and vagus nerve excitation stimulate acid secretion. That's why many people that they master these concepts, especially gastroenterologists, suggest patients to become vegetarian. There is a reason, right? Combined with hypersecretion, a rapid emptying of food from the stomach, reducing the buffering effect. So, the hypersecretion meaning a rapid emptying of food from the stomach, that translates to the rapid passing from the stomach through the pylorus to the duodenum, reduces the buffering. And we know the buffering is the process in which they are looking for a nice and stable environment. Buffering is nice and stable environment. Effect of food and delivers a large acid bolus to the duodenum. So the food is not completely processed in the stomach, has a lot of acidity in the bolus, and the bolus is transferred through the pylorus to the duodenum with a high acid bolus. Inhibitory secretory mechanisms and pancreatic secretion may be insufficient to control the acid load. So we have the pancreatic secretion, okay, which is the enzymes from the pancreas, amylase, lipase, and protease, right, that eventually are going to enter the duodenum, right? They are going to enter the common bile duct, I gave you a picture in the supplemental file so you can understand, but you should know your map at this point. In the common bile duct, okay, you are going to see, okay, it's in the supplemental. Look in the supplemental file that I always give you with all these videos, okay? So you have your common bile duct that is going to transfer enzymes from the pancreas, from the gallbladder, and the liver, okay? The common bile duct enters the duodenum, okay, and is going to be transferring all these enzymes. So basically what we know is the pancreas is releasing three enzymes: amylase, lipase, and protease. So even though these enzymes are being released into the duodenum, these enzymes are not good enough, okay, to process and break down the food that is transferring very fast from the stomach to the duodenum, okay? So let's continue. So where were we? Okay. So we have the rapid passing from the stomach to the duodenum. That's one factor with high acidity presence. And then we combine this with hypersecretion. A rapid empty of food from the stomach reduces the buffering effect of food and delivers a lot. Okay, so that's the first factor. Inhibitory secretory mechanism and pancreatic secretion may be insufficient to control the acid load. Yes, the pancreatic secretion is not going to help to reduce the acid load. Gastric ulcers usually develop in the antrum of the stomach, which is the part before the pylorus, okay, near acid secreting mucosa. So gastric ulcers usually develop in the antrum of the stomach near acid secreting mucosa. When a break in the mucosal barrier occurs, such as the one caused by H. pylori, hydrochloric acid injures the epithelium. Gastric ulcers may then result from back diffusion of acid or dysfunction of the pyloric sphincter. Yes. When the pyloric sphincter does not function normally, bile refluxes back up into the stomach. Okay, this reflux of bile acids may break the integrity of the mucosal barrier, will lead to mucosal inflammation. And that you can understand that by knowing your map, how your bile, in what part your bile enters the duodenum through the common bile duct. So we have a picture here of the gastric ulcer. You have the duodenal ulcer, pyloric sphincter, that if not working properly, the contents from the duodenal are going to reflux back into the stomach, right? Or the food is going to pass too fast from the stomach to the duodenal. Okay? Gastric emptying is often delayed in patients with gastric ulceration. This causes regurgitation of duodenal contents, which worsens the gastric mucosal injury, as we just described. Stress ulcers are acute gastric mucosal lesions occurring after an acute medical crisis or trauma, such as sepsis or a head injury. In the patient who is NPO, nothing peroral, for major surgery, gastritis may lead to stress ulcers. Patients who are critically ill, especially those with extensive burn, sepsis, or increased intracranial pressure, are also susceptible to these ulcers, stress ulcers. Stress ulcers are associated with lengthened hospital stay and increased mortality rates because its relation with this different type of diseases. Bleeding caused by gastric erosion is the main manifestation of acute stress ulcers. These lesions begin as areas of ischemia and evolve into erosions and ulceration that may progress to massive hemorrhage. So that's why it's very important. Okay, how can we monitor bleeding? Your vital signs, your RBCs, your pulse, your heart rate. Okay. Complications of ulcers. The most common complication of peptic ulcer disease, your PUD, are hemorrhage, perforation, pyloric obstruction, and intractable disease. Intractable means uncontrolled disease. Hemorrhage is the most serious complication, right? Many people have a second episode of bleeding if underlying infection with H. pylori remains untreated, or if therapy does not include an H2 antagonist of PPI, or if treatment does not include your H2 antagonist, which is your inhibition of gastric acid secretion, or PPI, your proton pump inhibitor, also inhibiting gastric secretion. With massive bleeding, the patient vomits bright red or coffee ground blood hematemesis. Hematemesis usually indicates bleeding at or above the duodenal junction, your upper GI bleeding. Minimal bleeding from ulcers manifests from a cold blood in a dark tarry stool, melena. Melena may occur in patients with gastric ulcers, but is more common in those with duodenal ulcers. And that's where the confusion comes. When we talk about melena, people, they understand that it's happening in the upper GI, right? But they get confused with hematemesis because melena is going to be noted in the stool, but hematemesis is the vomiting. Okay. Key features: upper GI bleeding. We spoke about hematemesis. We spoke about melena. Of course, we're going to see decreased hemoglobin and hematocrit, decreased blood pressure, of course, because we are bleeding, right? Increased heart rate, yes. Weak peripheral pulses, yes, that's a consequence of the decreased blood pressure. Acute confusion in older adults, right? We are losing blood, and with blood, we are losing oxygen. Vertigo, dizziness or lightheadedness, and syncope, loss of consciousness. So we have here common causes of upper GI bleeding, right? We have a very nice graphic. We can see the gastritis is how the inflammation of the mucosa. We have the gastric ulcer, gastric cancer, duodenal ulcer, esophageal cancer, esophageal varices. Very nice picture. Gastric and duodenal ulcers can perforate and bleed. Perforation occurs when the ulcer becomes so deep that the entire thickness of the stomach and duodenum is worn away. The stomach or duodenal contents can then leak into the peritoneal cavity. That's peritonitis. Sudden sharp pain begins in the mid-epigastric region and spreads over the entire abdomen. The amount of pain correlates with the amount of and type of GI content spilled. So more GI content is spilled, the pain is going to be worse. The abdomen is tender, rigid, and board-like as a result of this infection peritonitis. The patient often assumes a fetal position. Bacterial septicemia and hypovolemic shock can follow. Peristalsis diminishes and paralytic ileus can develop. Peptic ulcer perforation is a surgical emergency and can be life-threatening. Okay. NCLEX, first question. The nurse is caring for a client diagnosed with peptic ulcers. What would be the priority action for the nurse? Irrigate the NG tube, monitor vital signs, provide supplemental oxygen, or monitor bowel sounds. For basically is monitor vital signs because we need to monitor bleeding. Okay, so let's continue. Pyloric gastric outlet obstruction blockage occurs in a small percentage of patients and manifests with vomiting caused by stasis and gastric dilation. Obstruction occurs at the pylorus and is caused by scarring, edema, inflammation, or a combination of these factors. Symptoms of obstruction include abdominal bloating, nausea, and vomiting. When vomiting persists, the patient may develop metabolic alkalosis. When vomiting persists, the patient may develop metabolic alkalosis from loss of large quantity of acidic gastric juice, hydrogen and chloride ions in the vomitum. Is that metabolic alkalosis clear? Meaning that the environment becomes alkaline. Metabolic is the metabolism, right? It's related to the gastrointestinal. So it's becoming alkaline because it's losing acid gastric juice. Hypokalemia may also result from the vomiting or metabolic alkalosis. Okay. Etiology and genetic risk. Peptic ulcer disease is caused most often by bacterial infection with H. pylori. That's the terror of the GI tract, H. pylori, and long-term use of NSAIDs such as ibuprofen. NSAIDs break down the mucosal barrier and disrupt the mucosal protection mediated systematically by COX inhibition. Okay, we're gonna talk about COX later. Incidence and prevalence. Peptic ulcer disease affects about 4.5 million people in the US annually. Primary healthcare provider visits, hospitalization, and the mortality rate for PUD have decreased in the past few decades, in part because of the use of proton pump inhibitors and early detection and treatment of H. pylori. So we are doing a lot of endoscopies and tests for prevention of peptic ulcer disease. Assessment for treatment for H. pylori infection. We are going to ask the patient if they recently received treatment for H. pylori. We need to ask about corticosteroids, chemotherapy, or NSAID use. Also ask whether the patient has ever undergone radiation treatment. Assess whether the patient has had any GI surgeries, especially a partial gastrectomy or bariatric surgery, which can cause chronic gastritis. Okay, so many young people, I'm serious, between ages of 17 to 22, when they are minors, they are authorized by parents to get the bariatric surgery. Look at what they are getting into. The risk for chronic gastritis, pernicious anemia, okay? And if they get chronic gastritis, and if they start eating a lot of food in the street, or, poor hygiene when they cook their meals, whatever it is, they can get the H. pylori. So they are going to be in risk for gastric cancer. Risk factor for peptic ulcer disease. Check for alcohol intake and tobacco use. If they are getting food with a lot of tomato or caffeinated beverages. History and patterns of GI upset and pain, relationship to eating and sleep patterns. Because if you eat and then you go to sleep, the food is not going to be processed, right? And it's going to be delayed in the stomach. And probably you're going to have the food and the gastric content being refluxed to the esophagus. Okay. For example, if pain that was once intermittent and relieved by food and antacid becomes constant and radiates to the back or upper quadrant, the patient may have ulcer perforation. So you need to assess for all this. However, many adults with active duodenal or gastric ulcers report having no ulcer symptoms. Pay attention to that. Physical assessment, signs and symptoms, epigastric tenderness and pain, usually located at the midline between the umbilicus and the xiphoid process. If preparation into the peritoneal cavity is present, the patient typically has a rigid board-like abdomen accompanied by rebound tenderness and intense pain, peritonitis. Initially, auscultation of the abdomen may reveal hyperactive bowel sounds, but these may diminish with progression of the infection. Now, dyspepsia is the most reported symptom associated with peptic ulcer disease. Document orthostatic blood pressures and monitor for signs and symptoms of dehydration to assess for fluid volume deficit that may occur from a bleeding ulcer. Dizziness when in an upright position is a specific symptom a patient with fluid volume deficit may experience. Older adults may experience dizziness when they get out of bed and are at risk for falls. Laboratory assessment, what are we going to do? 3 simple non-invasive tests are available to detect H. pylori, and those are in blood, breath, and stool. Serologic testing for H. pylori antibodies is the most common method to confirm H. pylori. The urea breath test involves swallowing a capsule, liquid, or pudding that contains radioactive carbon urea. After a few minutes, the patient exhales. If the radioactive carbon is found, the bacterium is present. So this is, we're going to play a video here to see this one of these tests. I think we're going to see 2. Okay, let's watch the video first, and then we discuss this.
Hi, my name is Dr. Sharif Toloor, consultant gastroenterologist at Mediclinic Dubai Mall.
Dubai.
I'd like to talk about the breathing tests that we are offering via our recently launched gut health clinic at Mediclinic Dubai Mall. We offer urea breath test. Urea breath test is a test to detect for a bacteria called Helicobacter pylori, which is a very common infection of the stomach. This bacteria can cause a lot of problems. It can cause gastritis, erosions, ulcerations, and in rare cases even cancer. The test is aimed to detect for the bacteria. You are asked to come in after 4 hours of fasting and given a pill, and 30 minutes later you will be asked to blow into a balloon and we can detect the bacteria. So if you have symptoms of abdominal bloating, discomfort, pain, fullness, or any of the other symptoms, you may need this bacteria test. I'd like to now talk about HBT, or the hydrogen breath test. This test is aimed to detect for any bacterial overgrowth in the small intestine. As we know, we have millions of bacteria in our gut, especially in our intestine, and sometimes when the bacterial level gets imbalanced or the levels go high in the small intestine, you get symptoms. We aim to detect this with the breath test, which is called the hydrogen breath test. Basically, you come in after 12 hours of fasting in the morning and you'll be given a mixture of drinks, and over the next 3 hours you'll be asked to blow into a machine and we can detect for the bacterial excess, but also we can detect for any lactose or fructose malabsorption. So if you have excess gas, flatulence, abdominal distension, bloating, you may need this test. Thank you.
Excellent, excellent, excellent. So the stool antigen test is performed on a stool sample provided by the patient, which is tested for H. pylori antigens. Patients who have bleeding from a peptic ulcer may have decreased hemoglobin and hematocrit values, of course. The stool may also be positive for occult microscopic blood if bleeding is present. Now, other diagnostics, the most accurate diagnosis test for establishing diagnosis of PUD is EGD, esophagogastroduodenoscopy. Direct visualization of the ulcer created by EGD allows the primary healthcare provider to take specimens for H. pylori testing and biopsy and cytologic studies for ruling out gastric cancer. The rapid urease test is used to quickly confirm the diagnosis. As I told you, they take the biopsy, the tissue, and they put it in a container, and with chemicals they are able to confirm the diagnosis. GI bleeding may be confirmed using a nuclear medicine scan. No special preparation is required for this scan. The patient is injected with a contrast medium, usually technetium, and the GI system is scanned for the presence of bleeding after a waiting period. A second scan may be done 1 to 2 days after treatment for the bleeding to determine if the intervention were effective. So, what is the main problem that we need to work? What is the main factor we need to focus on? Acute or persistent pain due to gastric and or duodenal ulceration. And then we need to focus on how to relieve the potential for upper GI bleeding due to gastric and or duodenal ulceration. So you have this table, okay? NCLEX alert. You need to know your differences between gastric and duodenal ulcers. So your gastric starts with G, gerontologic. So it's from 50 to 70 years, on average of 68 is the gastric gerontologic population. Duodenal, 20 to 50. Most important, occurs 30 to 60 minutes, the abdominal pain in a case of gastric ulcer, 30 to 60 minutes after a meal at night, rarely worsening by ingestion of food. So at night, basically there is no problems. And then the duodenal occurs 1 hour and a half to 3 hours, so it's more distal from the esophagus, right? After a meal, and at night, often awakens patient between 1 and 2 in the morning. Relief by ingestion of food. That's the differential. Okay. Then response to treatment is going to be healed with appropriate therapy. Remission and exacerbations in the case of duodenal. Hemorrhage is going to be the gastric ulcer is going to present with hematemesis, more common than melena. And in the duodenal, melena more common than hematemesis. Cancer risk increase, but it's less than 5%. Duodenal, not increase. Recurrence, gastric ulcers is going to tends to heal and recurs often in the same location. And then duodenal, 60% recur within 1 year, 90% recur within 2 years. So those are your differentials between gastric and duodenal ulcers. So how are we going to manage acute or persistent pain? What interventions? We need to focus on drug therapy and dietary changes. Okay. Drug therapy, the primary purpose of drug therapy to treat PUD are to provide pain relief. Yes. Eliminate H. pylori infection. Yes. Heal the ulcerations and prevent recurrence. Okay, so a common drug regimen for H. pylori is going to be your PPI based triple therapy, which includes a proton pump inhibitor such as lansoprazole, plus 2 antibiotics such as metronidazole and tetracycline, or clarithromycin and amoxicillin, 10 to 14 days. That's to attack the pylori. Some primary healthcare providers may prefer to use quadruple therapy, which contains a combination of your proton pump inhibitors. They are going to inhibit the gastric secretion, and two commonly used antibiotics as described previously, and the addition of bismuth, which is a mucosal protector, right? Bismuth therapy is often used in patients who are allergic to penicillin-based medication. Okay, bismuth subsalicylate inhibit H. pylori from binding to the mucosal lining and stimulate mucosal protection and prostaglandin production. Teach patient that they cannot take aspirin while on this drug because aspirin is a salicylic acid and could cause an overdose of salicylates. Patients should also be taught that bismuth may cause the stools and or tongue to be discolored black, and that's good to know. NCLEX alert, safety, safety. This discoloration is temporary and harmless. Okay, so older adult health, patient-centered care. Many older adults have H. pylori infection that is undiagnosed because of back symptoms associated with physiologic changes of aging and comorbidities that mask dyspepsia. And because older adults sometimes they are not having the words, they cannot describe properly what are the symptoms. So some providers that are in a hurry during the doctor's appointment, they are not asking the good questions to get deep into the problem. Because the average age of gastric cancer diagnosis is 68 years. They're very young, right? It is important to teach older adults about the symptoms of peptic ulcer disease and to consider H. pylori screening. Hypersecretory drugs reduce gastric acid secretions and are therefore used for both peptic ulcer disease and gastritis management. The primary prescribed drugs include your PPIs and H2 receptor antagonists. Both are going to work in reducing the gastric acid secretion. Long-term PPI has become more prevalent over the past 2 decades. Recent studies have suggested there may be an increased risk for osteoporosis fracture related to long-term PPI, among other side effects that we discussed in the previous chapter. PPI should not be discontinued abruptly to prevent rebound activation of the proton pump. A step-down approach over several days is recommended. Nutrition therapy. The role of diet in the management of ulcer disease is controversial. There's no evidence that dietary restriction reduces gastric acid secretion or promotes tissue healing. So now I have a couple of questions. Let me finish. Although a blunt diet may assist in relieving symptoms, so that means that there's no evidence that by avoiding tomato, citric foods, minimizing the intake of alcohol, all these factors are not, there is no evidence that this dietary restriction is going to reduce gastric acid secretion or promote tissue healing. What about your aloe vera tissue healing? The fact that they have not conducted research study does not mean there is no evidence. That's my personal thought. Food itself acts as an antacid by neutralizing gastric acid for 30 to 60 minutes if you get the proper food, right? An increased rate of gastric acid secretion called rebound may follow. Bedtime snacks are avoided because they may stimulate gastric acid secretion. Yes, that's correct. No evidence supports the theory that eating 6 meals daily promotes healing of the ulcer. Okay, this praxis may stimulate gastric secretion, more often, right? You're going to have often acid secretion. Patients should avoid alcohol and tobacco because there is stimulatory effect on gastric secretion. Yes, so if they are going to minimize the gastric acid secretion, means that the body, at some point, if you prevent these causative agents, is going to start healing, right? I don't want to think that the body is only going to heal by getting PPI and antibiotics, right? Something must be done. Complementary and integrative health. Teach patient about complementary and integrative therapies that can reduce stress, including hypnosis and imagery. For example, the use of yoga and meditation techniques has demonstrated anxiety-reducing benefits. Many have suggested that GI disorders result from the dysfunction of both the GI tract itself and the brain. I told you, the GI is the second brain. This means that emotional stress is thought to worsen GI disorders such as peptic ulcer disease. GI is the second brain. It has the most number of nerves in the body after the brain. So I gave you in the supplemental file the health benefits of aloe vera by Dr. Berg. I played this video in a previous chapter. You have the link in the supplemental file. But okay, I'm gonna play the video again because I just remember we have students from other schools that are watching these videos and it's important.
I'm back for another short video, this time on aloe vera. I had a question about it, my opinion on it, so let's just talk about it. So aloe is very nutrient dense. It has a lot of minerals, vitamins, and phytonutrients. It's primarily good for two things. One, sunburn or acne. Okay, so it's good for the skin. Also, it can help psoriasis in the scalp and digestion. Specifically, things like acid reflux or GERD, ulcers, and inflammation, as in Crohn's, IBS, celiac, things like that. And it's also really good for constipation because it can act as a laxative. You just want to make sure if you're getting aloe that you don't get the version with a lot of preservatives and chemicals. You want to get it as natural and as concentrated as possible. It also has antibacterial effects. It's good for your blood sugars, good for the hair, it's good for the immune system, and it has antifungal properties. But here's the thing. Anytime you take any remedy, I don't care what it is, you're treating the symptom. You're not really getting rid of the cause. So when you do research on aloe, it's mixed all over the place. Why? Because of the big variable on someone's diet. If your diet sucks because it's filled with garbage, this remedy will not work. And this is really the basic problem of medicine. It focuses on symptoms, not underlying causes. Now, I can see if you get sunburn, right? This will work great on your skin because sunburn is not a dietary deficiency of something. But just as a side note, if you do have a burn, one really good remedy is vitamin D. Now, normally you get vitamin D from the sun, but you don't want to get any more sun if you're burned. But if you take vitamin D, it actually clears up sunburn pretty quick. That's just a side note. But I would recommend aloe vera and a lot of other remedies only after you fixed your diet, okay? Because chances are you probably won't even need this once you fix the diet. But I think people in general, especially in the medical field, do not connect the dots between all these symptoms that they're having and getting the diet corrected. If you're new to my channel and you don't know about keto and intermittent fasting, I put a link down below. Thanks for watching.
Thank you, Dr. Berg. Almost 12 million people are following Dr. Eric Berg, and he's connecting the dots between diet and GERD, ulcers, and all these topics. Okay, managing upper GI bleeding. What are we gonna do? The patient with upper GI bleeding, often called upper GI hemorrhage, is expected to have bleeding promptly and effectively controlled and vital signs within normal limits. So what are we gonna do? Blood loss from PUD results in high morbidity and mortality. So fluid volume loss secondary to vomiting can lead to dehydration and electrolyte imbalances. That's why I always say, please check your comprehensive metabolic panel. Interventions include preventions and/or management of bleeding, perforation, gastric outlet obstruction, in some cases surgical treatment or complication necessary. Non-surgical management, monitor the patient carefully. Emergency, upper GI bleeding. What are we going to do? The patient who is actively bleeding has a life-threatening emergency and needs supportive therapy to prevent hypovolemic shock and possible deaths. Okay, that's good to know. NCLEX alert. Monitor for hypovolemic shock. But the most important is you need to take action. So recognize a priority for care of the patient with GI bleeding, with upper GI bleeding, is to maintain airway, breathing, and circulation. Respond to these needs by providing oxygen and other ventilatory support as needed. Starting 2 large bore IV lines, one for replacing fluids and blood, and the other one for blood, as well as monitoring vital signs, hematocrit, and oxygen saturation, and that's NCLEX maximum alert. The purpose of managing hypovolemia is to expand intravascular fluid in a patient who is volume depleted. Okay, fluid replacement in older adults should be close monitored to prevent fluid overload. Serum electrolytes are also assessed because depletions from vomiting or nasogastric suctioning must be replaced. Volume replacement with isotonic solution, which is your normal saline, or lactated ringer solution should be started immediately. Provided also, the provider is going to prescribe maybe blood products such as your RBCs to expand volume and correct a low hemoglobin and hematocrit. So for those who don't remember, your lactated ringer injection is used to replace water and electrolytes lost in patients with low blood volume or low blood pressure. It is also used as an alkalizing agent, which increases the pH level in the body. It's not the injection, it's the lactated ringer's IV. Okay, I don't know what happened here. Okay, so let's continue. Another important factor is that when blood loss exceeds 1 liter in 24 hours, manifestation of hypovolemic shock may occur, including hypotension, chills, palpitation, diaphoresis, and weak 3D pulse. So I need to remind you that the human body has nearly 4 liters of circulating blood. So losing 1 liter within 24 hours is a problem. It's a life-threatening situation. Nasogastric tube and G placement, upper GI bleeding or obstruction after require the primary healthcare provider or nurse to insert a large bore NG tube to determine the presence or absence of blood in the stomach, to assess the rate of bleeding, to prevent gastric dilation, and to decompress to rest the GI system. So the endoscopic therapy is going to be during the EG. The healthcare provider will insert instrument through the endoscope to stop bleeding in 3 different ways. So it's going to inject chemicals into the bleeding site, treat the bleeding area with heat, electric current, or laser, or 3 is going to close the affected blood vessel with a band or clip. So they need to stop the bleeding in some way, right? Keep the patient NPO for this procedure for 4 to 6 hours before the procedure. This prevents the risk for aspiration and allows the endoscopist to view and treat the ulcer. We are talking about the endoscopic therapy. A patient must sign a consent form for the EGD after the primary healthcare provider advises and educates the patient about the procedure. It's after the education, but it's before the procedure, right? Just clarifying. Nursing safety priority after EGD, monitor vital signs, heart rhythm, oxygen saturation, that's good to know. Patient's ability to swallow saliva after EGD. Okay, the patient gut reflex may initially be absent after EGD because of the anesthesia. But after the procedure, do not allow the patient to have food or liquids until the gag reflex has returned. Okay, interventional radiologic procedures for patients with persistent massive upper GI bleeding or those who are not surgical candidates. Catheter directed embolization may be performed. And for this, a femoral approach is more often used, but brachial access may be used. An arteriogram is performed to identify the arterial anatomy and find the exact location of the bleeding. They need to go and need to do the embolization over there. The radiologist ingests medication or other material into the blood vessel to stop the bleeding. It's an emergency. Bleeding must be controlled. Drug therapy. Aggressive acid suppression is used to prevent rebleeding. Typically, they are going to use the PPIs of choice, and these drugs prevent the transport of acid across the parietal cell membrane. NCLEX question: the nurse is caring for a client who just had a EGD to treat GI bleeding resulting from a gastric peptic ulcer. Which action would be the priority for the nurse to take at this time? So they are going to assess the client's gag reflex, as we just mentioned, before offering any ice chip or fluids if allowed. Place the patient in a flat supine position? No. Monitor the client for a rigid board like? No, there's no peritonitis. Type and cross-match at least 2 units of packed red blood cells in case of bleeding. Surgical management. For some patients who have PUD, cervical intervention may be used to treat patients who do not respond to medical therapy or other non-surgical procedures. Treat a surgical emergency that develops as a complication of PUD, such as perforation. And there are two general surgical approaches are available for peptic ulcer disease, right? We have the minimally invasive surgery via laparoscopy, right? And in this procedure, the patient may have partial stomach removal, subtotal gastrectomy, that's another name, pyloroplasty also to open the pylorus if there is an obstruction, and or vagotomy, vagus nerve cutting to control acid secretion. Also, care coordination and transition management. Patient may be discharged from the hospital if there is no evidence of ongoing bleeding, orthostatic changes, or cardiopulmonary distress or compromise, meaning that the fluid volume is already under control. Self-management education. Home health care, the patient with peptic ulcer disease. We are going to assess gastrointestinal and cardiovascular status, vital signs, changes in bowel elimination pattern, bowel sounds. Hemoglobin and hematocrit is going to be assessed by the primary care. Assess nutritional status. This is the most important. Dietary patterns and habits, intake of caffeine and alcohol, relationship of food ingestion to symptoms, the drugs to avoid NSAIDs, need for smoking cessation, etc. Nursing safety priority, action alert. Teach the patient who has peptic ulcer disease to seek immediate medical attention if experiencing any of these symptoms: sharp, sudden, persistent, and severe epigastric or abdominal pain, bloody or black stools, which is your melena, right? Bloody vomit or vomit that looks like a coffee grounds, which is your hematemesis. And that's good to know. NCLEX alert. So we have finished this part of this chapter. When we come back, we're going to review gastric cancer. Okay? So stay tuned. Thank you for your attention.